Good evening. My name is Twyla McGinnis. I'm a registered nurse with over a decade of clinical experience at a leading teaching hospital in Boston. And I've also served as the Director of Nursing for the state of Rhode Island and as a Director of Accountable Care Organization Operations. Currently, I serve on the Nursing Advisory Board at Southern New Hampshire University, and I'm a proud board member of Primary Care for All Americans. On behalf of the board, I'm delighted to welcome you to tonight's Teach and Learn In Zoom session. And I want to thank you for joining us this evening. With over 1,400 people from 40 states and the District of Columbia and 350 zip codes, we are reminded of the incredible momentum we are building together to provide primary care to everyone in every American neighborhood and community. I thank you for your dedication and commitment to expanding access to primary care across the country. Now it's my great pleasure to introduce our moderator for this evening, Michael Fine, and to extend my sincere thanks to all of the presenters for tonight's event. I'd also like to thank the PC. Oh, my fire alarm's going off. Sorry. Take it away, Michael.
I'm here to put the fire out or something like that. I'm Michael Fine, President and Board Chair, Primary Care for All Americans. Welcome, everybody. I want to thank everyone for being here with us tonight. By joining us, you really are helping to build a movement, one that focuses on providing healthcare to people in every neighborhood and community across this country. That's Primary Care for All Americans. If you haven't shared your community yet, please do so in the chat so we can see who's here as we work together to build this movement. One of the things we do is to try to refrain from using professional titles. This space is about focusing on the importance of being here together, engaged in this work, and valuing the ideas and commitments that will ultimately drive this movement forward. Tonight, we're here to both teach and learn from one another. We encourage you to contribute by submitting your questions in the chat throughout the session, and we'll try to get to them as soon as Dr. Weaver is done speaking. Please stay with us at the end of the session, where we have a time for Q&A and discussion. We'll explore how you can help bring primary care to everyone in your own neighborhood and community, exercising the power of two. Now it's my great pleasure to introduce our keynote speaker, Dr. Don Weaver. Dr. Weaver is a friend, a mentor, and a true primary care hero. Dr. Weaver had a long and distinguished career as a commissioned officer in the United States Public Health Service, retiring with the rank of Assistant Surgeon General. He began his career in the United States Public Health Service as a National Health Service Corps volunteer physician, and Don, you'll have to correct me if I pronounce this wrong. In Tulele.
Tuella.
Say it again, please.
Tuella.
Utah, and then served in a variety of regional and national leadership positions with both health professions and service delivery programs in HRSA. A 1973 graduate of Harvard Medical School, Dr. Weaver completed a 2-year pediatric residency at Boston Children's Medical Center, and he currently provides consultation on clinical workforce and service integration and serves as Chief Medical Officer for the College for Healthy Communities and the Underserved. What a perfect name. Take it away, Dr. Weaver.
And Don's fine. Thank you, Michael. And thanks to the Primary Care for All American team for the opportunity to dialogue about a subject near and dear to my heart, as you probably gathered from far too much about me. I started on this journey as a National Health Service Corps volunteer quite a few years ago now. And what I've been asked to do tonight, so I will try to do it quickly so we can get to question and answers, is to do a brief history of the National Health Service Corps and reflect on some of the lessons learned that I think will be helpful for communities, not only for this program, but as they try to put together, I don't know, I always sort of view what needs to be done in primary care as kind of a jigsaw puzzle that has a lot of pieces and figuring out how you pull all those together. So let's get started. For those of you that are not aware, the National Health Service Corps was established by the Emergency Health Personnel Act of 1970. Interesting sideline is many people thought it was not going to become a law, and I think it was signed into law. For those of you that like to figure out which president signed which, by President Nixon, I think he was up at Camp David when it was done, but it was to address the maldistribution of physicians in the United States. It's how that bill became a law is written in a fascinating book. It's called The Dance of Legislation by Eric Redmond. And Eric was actually a staffer for the champion in the Senate, who was the late Senator Warren G. Magnuson from the state of Washington. The champion in the House that you read about in the book is Mr. Rogers, not the one that I like to watch on TV and in reruns, but Representative Paul Rogers from Florida. That first group went out in 1972. There were 181 placements of physicians, dentists, and nurses, so they were interprofessional from the very get-go. It's a small number in comparison to the interdisciplinary cadre of core clinicians, which, as reported in the December 2024 recommendations from the National Advisory Council, the number that were in the field at that point was 18,000. We'll talk a little bit about how it got from here to there in a second. But let's go back to that 181 initial clinicians. They were all volunteers. They were federal employees, either civil servants or commissioned officers in the U.S. Public Health Service. And there was an interesting provision when the federal government placed these federal employees in communities on the way that the community would reimburse the cost for those individuals. And it really ran along the lines of, for the first amount that you would get that could have paid for this person, 20% comes to the federal government, 80% stays in the community to continue the practice. For the next amount of that total, it was a switch. It was 80-20, and the thought being, we've provided you with technical assistance, we provided the clinician with technical assistance, now you have a financially viable practice, and this program can move into another underserved community. You'll see there have been many changes from that particular model. Term that gets tossed around a lot, I always mention it, is that all National Health Service Corps clinicians must be placed in health professional shortage areas, or HPSAs, areas that are designated as underserved, which, as many of you know, spell check likes to correct that many times and says undeserved, and of course nothing could be more untruthful than that. It's underserved people who lack access to care. 1976 was a banner year for the National Health Service Corps, and that's when the National Health Service Corps Scholarship Program was enacted to provide financial support in return for a commitment to serve in a health professional shortage area. Scholars were making a couple of commitments. They were committing to serve wherever the needs were the greatest, but they were also committing to a community as well. One of the things that limits that for a scholar is with a commitment to go wherever the needs are the greatest, no one knows what those communities are going to be on that list for any given year. So what we always would tell people is if you are tethered to a geographic area, nothing wrong with that, the scholarship program may not be for you. And so it was a way of getting choice, but not as much choice. But they said, yes, I'm going into primary care and I'm willing to go wherever the needs are the greatest. How the communities were selected, there was a scoring system and continues to be one for health professional shortage areas. What does that really do? Sadly, it determines needy, needier, and neediest. I've never been to a community that's a health professional shortage area that didn't believe that they were the neediest community in the nation, as they should, because it's their home and their community. But that's how the list sort of worked out as far as where scholars could go. Initially, the interest rate to buy out was fairly reasonable. I'm not sure what these days interest rates being fairly reasonable was, but at the time it was much less than what the going rate was. And there were a small number of scholars who used it as a loan program and bought out rather than serving. I mention that because those are the ones you tend to hear about. The vast majority of scholars did an amazing job, and their stories, ought to be written in books and it certainly impacted lives that the program is most appreciative of. That's why, if you follow the legislation for the Corps, the Congress said, no, this is a service delivery program. You're making a commitment to serve. And if you choose not to do that, it's triple payback plus interest. So people always ask, how did it get to that, draconian? It was because we wanted to make sure you knew what you were signing up for. And for some, and we were talking about this a little bit before we came on board, the scholarship program really enabled someone who wanted to realize a dream of becoming a health professional, a physician assistant, a nurse practitioner, a nurse midwife, but just didn't see where financially they could do it. It provided them an opportunity to realize that dream. I've heard a number of stories. I know it's anecdotal. I wish I had the data, but I do believe there's some significant number of National Health Service Corps clinicians where the scholarship program allowed them to, pursue their dream and were meeting a need in an underserved community. 1976 was also an important issue in that it was the time of the creation of the National Advisory Council for the National Health Service Corps, of which Michael Fine was a member after he served his National Health Service Corps commitment and advised the program. And I say that's an important piece because it's getting feedback from the communities about how's this program working, what needs to be changed. To give you an example, over the years, that was the group that got the National Health Service Corps, led the charge for the National Health Service Corps to get a 10-year reauthorization. That was the group that looked at finances and said, what you're offering for loan repayment is not large enough. It's going to be a problem getting people to use that as an incentive. So a lot of very important actions happened with that council and continue to do so, as I quoted from their December 2024 report. 1983 saw a model change. I mentioned all of those original people were either civil servants or commissioned officers in the U.S. Public Health Service. In 1983, a lot of it was because of funding and availability, the model changed that the clinicians were hired by the community organization and were no longer federal employees. And then in 1987, there was a look and said, we ought to have something in addition to the scholarship program. And that's when the loan repayment program and state loan repayment, a matching dollar program, were created. The advantage of that from a clinician's point of view is you match to a site, a place where you want to work in a shortage area. And then you apply for loan repayment. So, you have one program on the front end where you say, go where the needs are the greatest. I'll go anywhere. I would have never thought in my wildest dream, although I was a volunteer, that Jane and I would have ended up in Tooele, Utah. So glad it happened that way. But but with loan repayment, you can choose the site and then you work for that. There was and continues to be much more community and clinician demand for the programs than could be addressed. So what's the limiting factor? No surprises here, funding. And the ebbs and flows in field strength are really based on funding. So when you look at when it's higher or lower, and we'll talk a little bit about how we got to the 18,000 in just a little bit. And that really was due to the historic increase in funding through the American Rescue Plan. The field strength rose to over 20,000, and there were 3,500 scholars in the pipeline because of that historic increase. So ebbs and flows, a variety of programs, and subsequent adaptations with regard to the program. So one of the groups said, and Michael and I have talked about this a bit. I said it used to be people would say, I went back to school and they said, you're too smart to go into primary care. I always quote Larry Green. I give him credit for it. He says, primary care needs to be the smartest folks around. They need to know about everything as opposed to honing in on a subject for another time for a debate. But there's a lot of factors that don't nurture and support, going into primary care. And that's why one of the programs that the Corps developed was a Students to Service loan repayment program. So let's use medicine as an example, although it's also for nurse practitioners and physician assistants and dentists. You're in your fourth year of medical school. You've already matched to a primary care residency, and you are willing to commit to go to an area of high need to meet the needs of an underserved population. You can start loan repayment in the Student to Service program because, the Corps already knows you've got the primary care commitment. The only variable is going to be what's going to be on the list when you come out. But that's another option for people to not let debt incur over the next 3 years. When substance use disorders, were on the rise, perhaps still are, the substance use disorder loan repayment program was created. There's a rural community loan repayment program, all based on needs of the population in the community. And some of the more recent ones are maternity care target areas. I think a question many of us are asking is who's going to deliver the babies? That's with a particular focus on OBGYNs, certified nurse midwives, and family physicians who are doing deliveries in that particular program. There was a recognition that language was also a barrier. And so there's a Spanish language proficiency additional amount that can be achieved in loan repayment. And they also just recently increased the loan repayment amount for clinicians in the field. The good news is there's a loan repayment program for the National Health Service Corps, but perhaps not as equally good news is a lot of other entities that are recruiting from this limited supply of primary care clinicians are also offering loan repayment and other benefits. So we're really looking, and the Corps has always looked for that with clinicians who care. I always hearken back to when the National Health Service Corps was celebrating its 25th anniversary and changing its logo, which is pretty much what it looks like now. And after a bunch of focus groups that it recognized that the four elements were caring, compassion, community, and health. And, I think that's what the Corps is still about. Some of the people ask, are they retained? I must admit, in the early days of the Corps, I think people thought that there was going to be, in fact, I can recall being asked, well, when are we going to eradicate health professional shortage areas? Oh, wouldn't that be nice? But that isn't what the program was set up to do unless you funded it in multiples that are beyond my even thought process there. But in the 2023 report to Congress, the Corps did say approximately 86% of Corps participants who completed their service obligation in fiscal year 2021 continued to serve in underserved areas 2 years later. So they were able to look and see that that was the case. And that 87% of those who fulfilled their service commitment between 2012 and 2022, so that's a 20, that's actually a 10-year frame. They were either, and I've got to take a look at my cheater note here, excuse me, either still working in a HIPSA or have remained in the community where they served, even though it no longer qualifies as a HIPSA. It's the infamous catch-22. The good news is it's no longer a HIPSA because the person who was sent there to address the shortage has remained. I personally believe that anyone who's been in the National Health Service Corps is indelibly imprinted with sort of the core and meeting the needs and understanding that it's a privilege to serve the underserved. And I believe the Corps has been a successful model in addressing the maldistribution of primary care clinicians. So yeah, Michael also asked me to talk a little bit about some lessons learned. I think in reviewing the history of the Corps, I hope what you've seen is it's important to keep your eye on the prize and adapt accordingly. So whether that's a variety of programs, whether that's looking at what you can do budget-wise, whether that's, the prize is addressing the maldistribution of primary care clinicians across the country. I think another lesson is do more of what's working and change what needs to be changed. And that's where the advisory council was so important for us because there were things that they said, this needs to be changed. And they were in a position to do that. We work for the executive branch of government, so we take their advice, but it's nice when that advice comes and makes the changes that improves the program. From its inception, I think another lesson learned is primary care is a team game. And it's not just about physicians. It's about a whole host of teams. And who leads the team is going to vary depending on who the team is, and how you meet those needs are extremely important. The other thing that people have learned over time, and I think it's a lesson learned, is primary care providers need support. They need it personally, and they also need it professionally. They need mentorship and peer support as they're going through some busy, challenging times with a lot of expectations on them. And, the successful National Health Service Corps placements, the communities played an incredible role in supporting those individuals during their time of service. I also take this as a lesson learned to say there are still, communities and sometimes states that reflect and say, well, our HIPSA scores aren't all that high, so we're not going to take advantage of this program. I personally believe that's a mistake. I think you should take advantage of all the resources that the National Health Service Corps has to offer. There should be a good profile on the Health Workforce Connector for every community that is in a health professional shortage area. For a variety of reasons. People say, well, we haven't gotten a scholar because our HIPSA score isn't high enough, or we didn't make the loan repayment cutoff that year because the dollars appropriated weren't available. You know what? A lot of other people look at that health workforce coordinator as well. And you might find someone who's leaving a uniformed service and said, I've been in the Air Force for 20 years. Wow, I didn't know there was a place in Maine. So it's encouraging people to take advantage of that. And I think it's also important to define what you will say is success. And if success is that a person, if you're a community, comes to our community, stays in our community, that sort of adjusts what strategy you put together, as opposed to we need to get someone here to get things going. And if they'll stay with us, that's great. But if not, we still consider it a success that we got part of their time. I think part of everyone's strategy, and it's a lesson we've learned, is, you know, an integral part needs to be training, that you need to be training the next generation while you're also recruiting and looking. And it's one of those, I can't afford not to, because we're so busy trying to recruit and retain people. You can't afford not to look at that next generation and looking people in your communities. That would be the next cadre of healers coming out. And I think the last thing I would say is that the core being a piece of that puzzle, it's really important for lessons learned of who you partner with. How do you link with complementary programs, whether that's your area health education center, local training programs that are committed to primary care organizations and associations. It's figuring out how do you put all those pieces together and take what I believe has been a very successful program and fit it into what the strategy is for your community, for your state, and hopefully at some point in time for the nation. So I think I'll leave it at that, Michael, and see if there are any questions.
Thank you so much, Dr. Weaver. I really appreciate everything that you shared with us tonight. As we transition to a time of questions, we'll be looking at the chat to see if people have questions in there. Feel free to raise your hands. This is meant to be a Q&A time for everyone to participate in. I really appreciated, Dr. Weaver, how you talked about that this is a team sport, that we need to find partners. And I think that's one of the things as PC4AA that we are bringing teams together in local communities. And very interesting how you look at the scholarships for local communities. Is that something that you see as being a potential for these communities, is to offer scholarships with obligations and from a local level? Is there anything that they should perhaps think about if they want to implement a plan like that?
Great question. We've talked to actually just recently talking to a community about what they might look at. And I also asked them to consider whether they wish to put together a scholarship or a loan. And I say that because if it's a community effort and you said, we have enough funding now to fund, let's be optimistic, 3 people. And we'd like to do it as a loan because we want them to come back. And you write in the contract, that's exactly what you want them to do. The expectation is we'll cover this for you. This is what we'll do. And you will come back and serve for X number of years. I mean, the old loan repayment sort of idea was if somebody came back and fulfilled a commitment for about 5 years, by that time they've purchased a home. There's a whole host of things that bear a positive effect on longevity in that community. And you also write in what you hope doesn't happen, but again, you hear the news and the stories about, and one of the things that can happen is somebody. We talked about it before. My wife's from Swansea, Massachusetts. I'm from Missouri. I mean, how we met and we ended up in Utah. The joke is that she said, as long as wherever we live, it's close to salt water, and we were in Utah. I must have misunderstood what she had in mind, but. I said, it doesn't get any saltier than this. So I think you build in that there may be some penalties. There are some people who may be at an institution, let's pick on medicine for the sake of example, where it's not terribly supportive of primary care. And, they hear over and over again, you don't want to go into primary. Maybe they don't. And maybe they go into ophthalmology, which there's nothing wrong with that. But it also means it didn't get a primary care clinician into the community that sponsored them. So you write something in and you have to pay that fund back because that's what it was really invested to do. And it just recognizes for personal or professional reasons. One of the reasons I also encourage people to think about a loan pot is because you can also then take advantage of the National Health Service Corps. So if someone comes back and you're still a health professional shortage area, some of those loans can be repaid, and that helps build that pot back up again. You just have to look at the inner workings of what loans are and are not, not forgiven. It's not loan forgiveness, are not repaid. But if those loans can be repaid from, say, the community gets together and the bank does the loans and it meets all the core criteria, worst case scenario, they don't qualify for loan repayment, but they're back in the community and their loans getting paid off because the community might say, for every year you're here, we're forgiving 20% of your loans. And what I say to communities is, and when you look at that, those are recruitment costs that you would have incurred anyway without any assurance. Now you've got somebody who you're investing in, staying in touch with, and so I think there are ways to build that together. And yes, scholarships are a possibility too, but either way, I think it's a way for a community to say, this is something we want to do, and these are people we want to sponsor. And the end result gets to what I believe all of us hope, and that is that we get a workforce that looks like the communities that we're privileged to serve. So if you're from the community, that sort of tends to work out that way.
Thank you so much. I'm seeing a question that's coming through about how does the NHSC integrate with, and I don't know this acronym, Michael
FQHCs?
Kaplan. Yes.
Okay.
What is an FQHC?
Well, we'll do both. Okay.
Okay.
Interestingly enough, people use the term FQHC and community health center interchangeably. FQHC is actually a term of CMS, a federally qualified health center, and they can incur certain benefits. So that's FQHC. Other people will call them community health centers. They're in all the states and around the country. The Corps works closely with health centers. And actually, I think the last report that I read, about 50 to 58% of the Corps clinicians are currently serving in health centers. So particularly when there was a major shift in 1980, what did I say, 83, when they no longer were federal employees, health centers, hired a number of National Health Service Corps at that point in time scholars, to work there. And that continues to be the case. And many of them are long-term success stories. I mean, I could go around the country and tell you just some amazing stories of people who have been in their communities for 30 years and 40 years and are now in leadership positions at health centers across the country that came there via the National Health Service Corps. I don't know, did that answer the question?
Well, I hope so, but it's
my question. Yeah.
Wonderful. Thank you so much, Michael. I think that was you that asked that. And we will come back to more questions in case that sparked something else. I actually see a great question from Sarah Pastor that I'd love to come back to in just a minute. But for right now, I'm going to hand it back over to Michael and then Dr. Weaver, if you're willing to. We'd love to hop back to some questions in just a few minutes. Michael?
Thank you. We always take a break just for a second, right at 9 o'clock, to give people who only budgeted a half hour a chance to jump off. But we hope you'll stay on because we have major issues in this country right now around primary care, not just maldistribution, but an overall and huge shortage. A huge shortage, probably larger than anybody can actually imagine, that is driving all sorts of angst and chaos around the country. In Rhode Island, we just had a 25,000 person practice close with just a few weeks' notice, and everybody's running around trying to find a new primary care practice, and there aren't any. One large vertically integrated health system has a waiting list of 10,000 people that they think will take at least 2 years to address. And today, actually, in Rhode Island, the governor and the attorney general had dueling news conferences talking about their different ways of fixing primary care, none of which were really going to deal with the issue of workforce. And so I think you've just heard from Dr. Weaver critical observations about one way to approach workforce maldistribution. And now the opportunity is for communities to step up and turn those lessons into how we address the workforce shortage, which is so critical. But all that won't happen by itself. It will happen when each of us jumps in to organize or to support a local or state work group in your own community and help everybody see what the future looks like if we can get the workforce problem addressed, understanding it's going to take all hands on deck. So grab one other person, get started, organize a scholarship program, put up a gala and raise money for that scholarship program, organize a program at the high school for local kids so they choose primary care careers. Get on the board of your local community health center and get that community health center thinking about how to provide primary care to everyone in their own community, every single person. Now, which is the nut we all have to crack together. Or start a community-owned health plan. I think there's somebody on who's got experience doing that. We can bring these ideas and some of this experience and expertise to the table regardless. Don't wait. We'll help. Let's build something for everyone and build it together and come back and bring 3 people when you come back. Join us next in June when we'll be meeting again. We'll encourage everyone to invite someone new to get involved in this movement. Mark your calendars for our next Zoom meeting on June 3rd, when our own Gabrielle Yarrow will be speaking about how to involve policymakers in the work Primary Care for All Americans local work groups are doing in their own communities. We look forward to seeing you then and there. Register on our website, www.primarycareforallamericans.org, where you can also check out our local and state playbook. You can volunteer and you can donate to support our cause. Before we go back to questions, I'd like to reintroduce Twyla McGinnis, one of our board members, who will talk about how you can support Primary Care for All Americans and why your help, even if it's only a few dollars a month, is so important. Twyla.
My ask of you is simple. In every state in this nation, people are struggling to find primary care practices and clinicians. I myself have seen the value of primary care. I know we need a healthcare system that is for people, not for profit. You can make this happen in 2 ways. First, by volunteering in your own community, and second, by responding to the email that you'll receive soon and contributing some or as much as you can monthly to Primary Care for All Americans. I do. Please join me and help us build this movement. Primary care for everyone in every American neighborhood and community. Thank you.
Thank you, Twyla. And then Patty, let's go back to you and help us through some more questions.
Wonderful. Well, I think I had mentioned before that I saw something come through from Sarah Pastor, who's been an amazing partner with PC4A and leader with PC4AA. Sarah, are you willing to come off of mute and sort of present and ask your question with Dr. Weaver?
Yeah,
Give her
hi.
a
Thank
second.
you for your presentation,
Hey,
Dr.
Sarah.
I once considered joining the National Health Service Corps myself, but went Army instead. But I know
That's
that
okay. I think the public health service uniforms are nicer, but that's all right.
fair. I have been learning about I guess the leaked draft HHS budget, and it looks like a lot less money than was originally requested is proposed in that budget for the National Health Service Corps. It's not a clawback from what was received previously, but it's, I guess, keeping it flat and probably falling short of what you need. And so I was just wondering if you could speak to that and tell us, will there be any adjustments that you have to make or any adaptations in your plans?
Well, in fairness, I'm not at the program any longer, but adjustments would need to be made, I think. And I think there's a couple things. Number one is a real advantage, and I didn't mention this, of the scholarship program is when that's funded, it's funded for the duration of while someone's in school. With loan repayment, and I think they've moved, I think they're still doing 2-year contracts that can then be renewed over time so that you can spread out the funding. And what it really does, similar to what I mentioned, but sort of the peaks and ebbs and everything that goes along with that. I think there will need to be some adjustments made. One hopes, and I think this would be the wise counsel of their advisory council, and hope that that's in place to do that. Is you'd still need a combination, I think, of scholarships and loan repayment. And I think regardless of what the dollar amounts are, you really want to have both of those combinations in hopes that over time maybe that part would increase. But yes, two things. Number one, that major influx of funding, which got the field strength up to, I mean, astronomical numbers, which was great. That's going to be a big drop down with regard to that. And then a level funding, isn't going to allow you to expand the way you would like. So it's going to make needier and neediest even more difficult. But I think, as I guess people are looking at things, at least it keeps the program, afloat. And, I think you need to continue to document success and talk about the role that it plays in meeting the needs of communities. So yeah, I think there is going to be some significant belt tightening that'll need to be done. But just the people that I know that are at the helm at this go around, they're good folks, and I think they'll do everything they can to make sure that it's, as viable as possible for all the variety of different programs that are out there. I don't know if that answers it or not, but yeah, it's
Oh,
going to
yeah,
be.
that's really good to hear. I mentor a student who's applying to that program and wrote her a letter of recommendation, and am keeping my fingers crossed for her. So it's good to hear that the program will remain sustainable.
I would be surprised if there aren't scholarships and loan repayments available. And I thank you for encouraging, as that mentoring, I think is so important. And I mean, I think Michael alluded to it. I mean, we need folks out in the K through 12 and everything just to let people know about primary care and what are the opportunities that are there, but also people that are meant, you have someone applying and you say, yes, apply for this program. It's a great program. One of the slogans a while back was communities in need with clinicians who care. And I think, the more clinicians we can find that care and want to go out where others have chosen not to go, I think it's a great opportunity. So yes, continue to encourage them.
Yeah, thank you.
Thank you so much, Sarah. I wrote down earlier something about, the team and the every professional needs support and defining goals and success. And there was just a lot with that. One thing that you had also brought up, Don, I think Paul addressed in one of his questions. Paul, you were asking about the maternity deserts. Do you want to come off mute and sort of ask your question and open that discussion up?
Sure. While I was listening to this, I was looking this up. Because I live in Washington State, where in the east side and the rural areas, people vote red, and they also have maternity deserts where there's nobody in the county who delivers babies at all. So I was just looking for where's the resource and who's counting this, and it turns out it's the March of Dimes. And they have identified 1,000 counties today, I shouldn't say today, as of late 2023, 1,000 counties that are maternity deserts. And I'm presuming that means there's nobody from the National Health Service Corps in that county, or they wouldn't be a maternity desert. So what it implies to me is that the program is way too small for the needs that are out there.
Yeah, I think you're spot on, Paul. It's why one of the new designations that they did dealt specifically with that. And I know we've talked for years about who is that going to be. There are increasing numbers of family physicians who don't do obstetrical care. The more rural you get, you're not going to find many OBGYNs. And, thank goodness for Frontier Nursing University and other schools that are training an amazing cadre of certified nurse midwives who are out there doing a great job. And we need many more of those. So, yeah, I think bias, woefully underfunded, because we do need to address those issues.
Yeah, I think that's a great point of, there's the mental health piece that is being continually addressed again and again. I'm hearing from these conversations that we've had. We had a great speaker a few weeks ago, I think maybe 3 or 4 speakers ago, who talked about reproductive health care, how women, specifically millennial women, are not going to see a PCP while they are during their reproductive seasons because they're having babies. They're not doing the rest of their care, which I was guilty of as well. But between addressing all these issues and knowing that there is burnout happening, how does the health core fit in with that, right? You know, you said something earlier about needing to make sure that we're not just caught in the moment, but looking to the future for students. So there is a question in there somewhere, I'm sure, but you know, how do all of these players sort of work together from your perspective?
I mean, it's interesting. When the core was much smaller, there were gatherings both on a regional and national basis where people would get together and talk about some of their issues. I think that's going to be more and more now. You know, as we were talking about a bit before, Michael, that I think that's going to be more and more of a local activity. But I think being aware of that, and whether that's training programs, I mean, the last thing you want to have happen is to send students out to, receive an educational experience with a primary care provider who's looking burned out, said, if I ever had to do it again, I wouldn't do this, you know, kind of thing. So I think supporting them and what their needs are, I think is extremely important. There are organizations that do it. You know, there are some of the professional societies do it. Some of it, you know, is just linking up with a cadre of folks that are, I mean, I know a lot of them that are involved in health centers where they get together and talk about things. And if you're on the dental side, that's the National Network for Oral Health Access, where they share a lot of their particular issues. You know, on the clinical side, there's the Association of Clinicians for the Underserved. And I think people are really trying to look at what do you do to support and nurture and use the one that's a sort of a byline for, you know, and don't forget the other family and family medicine, and that's your family, you know, and making sure that people have a reasonable life along with, you know, the incredible commitment they've made to heal others. So yeah, it's not easy. But there are a lot of partners out there. That's why I say you know, and I think when people look, I specifically mentioned because I have a special place in my heart for the Area Health Education Center program. Those folks do some amazing things, and they can link and bridge academia. And I think that's just an opportunity that whomever's there and doing it, it's the kind of support that's needed so we don't lose the folks that are out there doing a good job. And that comes through loud and clear in the most recent advisory council reports. This needs to be done.
It's one of the things we're a little worried about in Rhode Island with this 25,000 person practice closing. Some of the policymakers thought the right approach was to get existing clinicians to take more patients. And that it's sort of painful to see that, because I think most of us understand that, you know, if you try to flog a dying horse, it dies. And we want to make sure that doesn't happen. So I'd rather personally see everybody get together, roll up their sleeves, and start opening new residency programs and for nurse practitioners and PAs and family doctors. I mean, we've got to expand our numbers. We're training just a tiny fraction of the number of people we need to train. You know, something like, you know, there are 4,400 medical students a year going into primary care now, into a shortage that's probably 40 to 100,000. We're not even keeping up with retirements, and that's where we're, at least in Rhode Island, and I think Rhode Island is the best supplied state for primary care, the fourth best supplied state for primary care in the country, and we're in bad trouble. So I suspect every place else is, and that's where we need communities to step up and really not only work to retain people and send scholarships, but develop training programs and new medical schools and new nurse practitioner schools. We're going to somehow have to do it all at once.
I'm looking at my screen, and George, you've been very patient with your hand up. Did I?
George?
Yeah. George, do you want to come off mute? Oh, there you
Yeah,
are.
Patty, thank you. Is it okay if I talk, Patty?
Oh, absolutely. Yeah.
Okay. Thank you. And let me lower my hand here. Thank you, Dr. Weaver. Really great material. Yeah, and I think we all on this call, I think, share the view that we've got to get more doctors and nurses, primary care. Um, we've been trying to put forward the idea that there's a lot of things that doctors and nurses are currently now doing in the clinic in terms of data collection, data vetting, um, data improvement, data analysis, and guidance and documentation preparation that are things that um, systems, computer systems, whether they be AI based or not, is an open question, but computer systems can do a much better job of than human beings. And if you could take those tasks off the back of clinicians, that would be one way to reduce their workload. It's kind of a new division of labor. The other way to bring more resources to the fore is to give patients the tools that they need to be able to report through their smartphone that they've got chest pain, and they send that into their primary care physician's office, and the primary care physician doesn't have to do anything about that right away. But if the medical assistant who's been trained to respond to that can activate a series of questions that are sent back to the patient about his chest pain, and the questions come from the literature, not from the peer-reviewed literature, not from the doctor, that then they would be able to answer those questions. Those answers would come in to the analytics engine, which would produce a set of guidance options that then the primary care doctor or the nurse could take a look at. So the idea is that the patients themselves can become, with remote patient monitoring devices that send measures into, again, not a person, but a machine to vet these values, that there are three possible new primary care providers: the patients themselves, the health coaches and social workers and all the other ancillary people, community health workers, and the systems themselves that could take a lot of what doctors and nurses are currently trying to do, take those tasks off their hands, and you'd probably get a better management of illnesses that way, because the patient themselves would be involved in the process. So just
Can I turn that into a question?
yeah.
And the question I think that underlies that is, Don, how do you think that would work vis-a-vis the care, access to care that's maldistributed, and how do you think it would work for the care of the underserved, particularly people who have, access issues around language, and around computer knowledge and so forth?
Yeah, I mean, I think it can work. I don't know how much of it is electronic and how much of it is the broad. I mean, I have a pretty broad definition of the healthcare team, and George, you alluded to that. I mean, community health workers understand the community, are trusted in their community, frequently speak the language of the community, and so I think having them as part of what feeds in, I think, would be extremely important. The more rural you get, the less technology availability you have. At least we're still struggling with that. But I think we need to look at ways, if I hear you correctly, George, that it's let's figure out the task that right now the primary care clinicians are doing that they don't need to be doing. Someone else can do it, as part of the team. And it's not that you can't do it. We used to talk about that all the time. Could I call and make the social work arrangements, et cetera? could, is that the best use of my time? Not because of a hierarchy or anything else, just saying that's really not my, skill set. I can do it because the patient needs it. But I think, and whether that's electronics or whether that's a broader team, certainly behavioral health is doing that with peer counseling and other things. I think it really does then get to, maybe not needing as many. We still need a huge number, but we might be able to meet some of those needs with other members of the team and with, some of the technologies that are available.
Yeah, because I think that social determinants of health, a lot of those can be addressed by social workers, health coaches, health coordinators, and those, as you know, explain about 80% of a person's health status.
Yes. Yeah.
Remembering that the center of primary care is relationship itself.
Mhm.
The
Yes.
relationship between the clinician and the patient is the thing that matters, that brings people to primary care and lets us make the transformational changes that happen that come out of those relationships. And I don't think anybody wants to see those relationships watered down or disrespected. We got to we got to keep on keeping those relationships at the center of what we all do. I think we're about out of time. Thank you, Don, for your lifetime of work serving the underserved. And thank you for taking the time with us tonight. We also appreciate every single one of you who came on tonight to ask questions and to think together, and who are helping spread this movement across the nation to help get the change the nation needs and deserves. Please take a minute to complete our survey. There's a link in the chat, I hope. We want to hear from you. And we'll see you on June 3rd. Thanks for being who you are, doing what you do. Let's keep doing this, and let's fix this ridiculous mess. Thanks to everybody. And hope to see you everybody on June 3rd with about 10 other people each, at least 10. Good night, everybody.